I will when I introduce. Good afternoon. Thank you for your patience and welcome to the Tuesday, February 24th meeting of the Joint Standing Committee on Health and Human Services. I am Representative Meyer and I'll be presiding over a public hearing today and then the first of several work sessions on the HHS portion of the supplemental budget. The purpose of the hearing today is to invite testimony from members of the public regarding proposed legislation before our committee. Today, as I said, we will hear LD 2103. We'll take testimony from people present and on Zoom who wish to speak for, against, or neither for nor against the bill being heard here today. With leave of the chair, committee members may ask clarifying questions of the person testifying today. The public hearing is just for that. It's for the public. The committee will have time for deliberation and debate at the work session that will be scheduled within the next few weeks. Whether you testify or not, you could submit written testimony to the committee right up until the day of the public hearing, which the work session, which will be scheduled over the next couple of weeks. Please be mindful that testimony is public and available to all once presented. This hearing is live streamed on both the legislative and the YouTube channel, and there's a recording of the meeting. Please silence your electronic devices, including those of us here behind the horseshoe. Some of our committee members will come in late. They'll come from and two other committees, and so you'll be seeing us come and go. You'll also see committee members eating and drinking behind the horseshoe. We would ask that you refrain from eating, but feel free to drink water here in the committee room. With that, I'll ask our members to introduce themselves, starting to my right with Representative Graham.
Thank you, Madam Chair. Good afternoon, everyone. Again, sorry we kept you waiting a little bit. I'm Representative Annie Graham. I serve the people of North Yarmouth and the Majority of Gray House District 105, and it is a beautiful sunny winter day.
Hi, I'm Representative Lucian Daigle. I represent House District 1, the northernmost part of Maine, where we'll have the Can-Am Crown Sled Dog Race starting Saturday.
That's this weekend.
Hello, good afternoon. My name is Flavia De Brito. I represent House District 64, which is part of Waterville and part of Winslow.
Good afternoon. I am Sam Zager. I'm honored to represent District 116, which is part of Portland.
Good afternoon. I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, along with 16 communities in eastern Hancock County, beautiful down East Maine.
Hi, I'm Michael Lemlin. I represent House District 53, Chelsea, Randolph, Pittston, and Dresden.
Hi, I'm Ian Fredericks. I represent House District 143 in Sanford.
Good afternoon. I'm Representative Dan Shigori, and I represent House District 55, the communities of Hollowell, Manchester, and West Gardner.
Good afternoon. My name is Julie McCabe. I represent District 93, part of Lewiston.
And on Zoom, Representative Griffin.
Good afternoon, everyone. My name is Abigail Griffin. I represent House District 34, which is Glenburn, Levant, and Cadescag.
And we are joined today by our nonpartisan staff from the Office of Policy and Legal Analysis, Sam Seneft, and our very capable clerk, Sophie Dubé, who it is my understanding is celebrating a birthday today.
Yeah.
Happy birthday to you. Happy birthday to you. Happy birthday, dear Sophie. Happy birthday to you. And many more.
Oh, okay. So we'll take testimony from people in the room and on Zoom in the following order: those in support of the bill, those opposed, those neither for nor against, but with additional information for the committee to consider. We will give Members of the public, priority when taking testimony. Only the bill's sponsor and co-sponsors of the bill will be recognized before the public. We run a 3-minute clock on testimony. You'll see the clock in the front of the horseshoe. As you're approaching the 3-minute point, please wrap up your testimony. We do not run a clock out of respect for the department when they come up and provide testimony, nor do we run a clock on legislators. If you have prepared testimony, please provide 20 copies to our clerk. You can leave those copies at the end of the horseshoe next to Representative Lemelin, and then sign in at the podium. And we thank you, as always, for joining us today. With that, I will open the public hearing on LD 2103 and welcome its sponsor, our own Representative McCabe, to introduce the bill.
Good afternoon, Representative Meyer and my esteemed colleagues on the Health and Human Services Committee. My name is Julie McCabe, and I'm honored to represent District 93, part of Lewiston. I'm here today to present LD 2103, an act requiring hospitals to adopt cybersecurity plans. The goals of this bill are straightforward. 1, to help prevent cybersecurity attacks on our hospital systems, and 2, to ensure continuity of patient care when future cyber attacks inevitably occur. This legislation was born out of 2 separate cyber incidents last spring, impacting 5 main hospitals: Covenant Health St. Mary's Hospital in Lewiston and St. Joseph's Hospital in Bangor, as well as Central Maine Medical Center's hospitals in Lewiston, Bridgeton, and Rumford. In addition, outpatient doctors' offices were also compromised, meaning more than 400,000 patients, nearly a third of all Mainers, were impacted. These impacts expose wide-ranging and serious breakdowns in hospitals' communication and triage protocols, which ultimately threatened patient care. The cyber attacks on CMMC crippled basic communication services. Because networks were down, you could not place a call to your doctor's office or send a patient portal message. Because you could not call outpatient offices, the number of missed appointments significantly increased, including for vital preventative care like mammograms and colonoscopies. As you will read in one doctor's testimony, due to the communication disruptions, access to critical prescription medication was also undermined. Instead of calling the office for a prescription refill, as one would routinely do, you had to physically go to the office to pick up a paper script. As we know, transportation to the doctor's office can be challenging to obtain in the best of times, notwithstanding a cyber attack. I spoke with one Auburn resident for whom this delay created life-threatening circumstances where she was forced to ration her insulin medication. I remind you, this communication outage continued not for days, but for weeks on end. Not only was preventative care impacted, but other highly acute healthcare needs were also not met during this period. For instance, oncology care for cancer treatments came to a halt because the technology used for radiation treatment could not be safely deployed due to the ongoing network breach, meaning for several weeks last June, cancer patients could not begin or continue their time-sensitive radiation treatment. Additionally, basic imaging and monitoring technologies that many of us take for granted and assume will always be there were also forced offline. That meant that in the labor and delivery unit, the central fetal monitoring system, which tracks newborn babies' heart rates, was down. Nurses had to monitor individual patients at the bedside, creating inefficiencies and forcing patients to be diverted from their local maternity unit to hospitals further away. Patients that required CT scans to monitor aneurysms, strokes, or other potentially fatal conditions could not access past imaging or get new imaging done. Because of the inability to provide these critical services, some were diverted to other hospitals. But often this diversion depended on patients' transportation access and tenacious self-advocacy. And for other patients, diversion to different healthcare facilities simply did not take place, leading to further delays in care. What is plain is there were severe breakdowns in patient care caused by the 2 cyber attacks. As I learned about this issue, it became clear to me that this is not a one-off or some fluke, but part of a trend of bad actors increasingly targeting hospitals. Cyber attacks on hospitals have doubled since the pandemic, and in 1 year alone, the number of exposed patient records grew from 5 million in 2024 to over 15 million in 2025. Threats to our hospitals are not a problem that we can outrun. This legislation calls for the following common sense steps to harden hospital cybersecurity systems and strengthen post-incident response plans to ensure that patient care continues to the maximum extent possible. These include mandating annual training for all staff, conducting annual penetration testing, and requiring that hospitals run tabletop simulations of cyber attacks. Requiring hospitals to write cybersecurity plans so that these plans be externally audited by professionals who will be able to assess vulnerabilities. And requiring planning for restoring the most critical networks and medical technology based on patient acuity and the hospital census. Measures in this bill that are focused on improving the post-incident response include requiring that hospitals and nearby health organizations engage in mutual aid compacts and create plans together to facilitate care continuity. Annual training for downtime charting and annual review of downtime documents to ensure that they are up to date and correspond to best medical practices. Annual input on the post-incident response plan from frontline workers, and publicly available instructions for employees on how to file a complaint to DHHS. A backup communication plan for hospital personnel to enable workflows between patients and doctors and between staff, again, to facilitate continuity of patient care. And a dedicated triage line in which patients are responded to based on their level of need to ensure timely access to medications, testing, imaging, and medical treatment. I also included a provision by which the Maine CDC's Public Health Emergency Preparedness Medical Response Team can be activated during a cyber attack if deemed necessary by the Maine CDC. Currently, the Maine CDC's Medical Response Team, comprised of volunteer healthcare providers, must be invited to aid in a public health emergency. I believe that the government should be able to assert its authority in an emergent situation to ensure patient care continues to the fullest extent possible. Finally, we do not yet know the true impact on patient health caused by last spring's cyber attacks. We do not know how many appointments were missed, how many prescriptions went unfilled, or how many radiation treatments were missed. Accordingly, this bill calls for a full accounting of that impact, as well as of future cyber incidents. We cannot expect to become better prepared and more resilient without conducting a thorough analysis of what worked and what did not. It is easy to become a nerd to the data breaches of personal information that we have all experienced. They are part and parcel of modern life. However, when breaches cripple basic healthcare services and become life-threatening, we cannot afford to be complacent. We must take immediate action to ensure hospitals are prepared and patient health is protected. I thank the committee for their thoughtful consideration of this bill, and I'm happy to answer questions you may have. There are also other experts and frontline workers in the room who may be able to speak to your questions.
Thank you, Representative. Thank you for bringing this bill forward. Questions from the committee? Yes, Representative Frederick.
Thank you. Thank you, Madam Chair. Just one question. What is annual training for downtime charting and annual review of downtime documents to ensure that they're up to date?
So during the cyber attack, the networks were down because there was a breach and they hadn't found it yet. They didn't find it initially for 2.5 months at CMMC. So that forces hospital systems to go to paper charts. And so I believe that all staff should be trained on how to paper chart effectively, efficiently. And so you don't have to rely on veteran staff to train new workers. I think it should be a part of orientation and annual training. And then there was the second part of your question. That it's annually updated. Yes, to my knowledge, at CMMC, they were using 20-year-old downtime paperwork, which is a problem because medical practices have changed.
Yes, so could you explain that more, that which would correspond to the best medical practices? You were almost going to describe it.
Yeah, so if we have new methods for tracking patient health, then that methodology should be in the downtime paperwork so that we're not missing important information when we're assessing patient health. And so that's why every year we should be updating the paperwork.
Seeing no other questions. Thank you. So we'll begin with testimony in support here in the room.
I have to begin by telling you, I'm reading this for my wife. She was ill today and wasn't able to come, so
Well, thank you.
I'll
Welcome.
let you know. So, dear Representative Meyer and honorable members of the Health and Human Services Committee, my name is Ann White. I live in Green and I'm an AARP volunteer. I'm writing in favor of LD 2103, an act requiring hospitals to adopt cybersecurity plans. Thank you for the opportunity to express my opinion regarding this bill. In April 2025, I was diagnosed with squamous cell carcinoma, easy for me to say, of the tonsil. And because I was unhappy with the delay in this diagnosis, which I felt was partially caused by my previous primary care practitioner, who was unaffiliated with Central Maine Health Care, I was happy to learn that there was a new PCP in Auburn who was taking patients. I called Central Maine Healthcare and scheduled my new appointment for June 2025. A few days before my appointment, the office called to cancel and said I would hear back within 2 weeks. After hearing nothing for 3 weeks, I called back, but found it difficult to reach anyone who could help. I couldn't reach the actual doctor's office, and although the main switchboard offered to have them call me, I never got a call. During this time, I had undergone surgery and was recuperating and waiting to learn the pathology results from lymph nodes removed during a neck dissection. Already concerned about my health, this issue added to my stress and worry since I was in between PCPs and unclear who to contact if I needed a new referral. In the end, I was lucky that I was finally able to connect with someone in the office, had my appointment, and I'm happy with my new PCP. I think this bill would help prevent the confusion and worry that I and many others experienced during the cyber outage and when we were unable to reach the hospital. My hope is that with the preparation suggested in LD 2103, the hospital will be able to respond to future attacks with better communication for their patients and clients. Thank you for taking the time to hear my testimony. I hope you will vote to pass the LD 2103.
Thank you. Thank you for delivering Ann's testimony. Questions? Seeing none.
Thank you.
We're very pleased to see the Honorable Margaret Craven joining us today.
Thank
Former
you.
member of this committee, many years.
I'm
and
delighted to be here and thank you.
Veteran legislator.
Well, good afternoon, Representative Meyer and honorable members of the Health and Human Services Committee. My name is Margaret Craven and I live in Lewiston. I'm here today to speak in favor of LD 2103, an act to require hospitals to adopt a cyber security plan. I paid my due diligence and
We saw that. Thank you.
on May 26, 2025, there was a massive data breach at St. Mary's Hospital in Lewiston. And on June 1st, 2025, CMMC, also located in Lewiston, was attacked, as were Bridgeton, Rumford, and the Rumford hospitals, which are operated by CMMC. Covenant Healthcare, from which I get my care, said that 478,000 patients were compromised, including 285,000 Mainers. Because of the breach, patients from both systems were left waiting for test results, appointments, and medication refills. My annual checkup was changed from August 2025 until February 2026. A friend about my own age was suffering from a severe hemorrhage, but she couldn't reach her doctor and couldn't get treatment in the Lewiston hospitals. She had to drive to Portland. The information accessed in May includes names, social security numbers, addresses, and treatment details. Experts say that attacks like this have been on the rise for years. Between 2018 and 2023, there was a nationwide 239%, and 2024 was the highest number of individuals affected. This is according to the HIPAA journal, which analyzes data and breach statistics. That's supposed to be statistic. Everyone I know who gets services at St. Mary's is getting letters letting them know that their information has been compromised. I've received 2 of their letters already, and then one telling me how I can track for trouble. I think this is an issue we all have a stake in. Not knowing if your credit or your personal resources are at risk is a stress we can do without. I'm asking you to please vote in favor of LD 2103. Thank you very much.
And thank you, Honorable Margaret Craven. Questions from the committee? Seeing none.
Thank you.
Noisy.
Good afternoon, Representative Meyer and members of the Health and Human Services Committee. I have no handout because I helped Margaret edit and type and copy her and so I fully endorse what she had to say.
Thank you.
I speak to you as a retired surgeon who worked at both St. Mary's and CMMC from 1977 to 2010, back in the dark ages of analog pre-medical. I retired just in time to escape the electronic medical record. But now you go on to a nurse's station, no nurses, they're all glued to their screens. They don't stand up and bow to the doctors as they once upon a time did. Anyway, there's no going back to that paper trail, except, as Julie just said, we have to be able to write what we mean. And I'm just getting ahead of myself. I also got my treatment at St. Mary's, and I've got the same kind of letters. So I've had it, I can see it both ways. And I can only imagine what the doctors and the surgeons at these hospitals must have been very frustrating. First of all, having just come through COVID, where it upset the apple cart, now to have to not be able to do this operation or see Mrs. Jones for her squamous cell carcinoma of the tonsil. So I fully endorse the 2103 legislation.
Thank you. Questions from the committee? I'm seeing none.
Good afternoon. Good afternoon, Representative Meyer, members of the Committee on Health and Human Services. My name is Bridget Quinn. I'm an Associate State Director of Advocacy and Outreach with AARP Maine. And on behalf of our nearly 200,000 members in the state, thank you for the opportunity to share testimony. And also thank you, Representative McCabe, for bringing forward this bill. Data security is a growing area of concern and an area for legislation to address. As you know, the legislation brought forward to you today is in response to a real issue in data breach that affected Mainers. The American Hospital Association reported that healthcare had the most reported cyber threats in 2024 than it ever had before. Considering the growing area of cyber threats and attacks, AARP has worked to develop our own policy framework regarding legislation that seeks to prevent and reduce harm caused by such attacks. We support policy that safeguards consumer choice and control, ensures heightened protection of sensitive data, promote privacy and security by design, foster transparency, and ensure accountability. We feel these are the principles reflected in LD 2103, and the fact is that cyber attacks have a real effect on healthcare consumers. They cause delays in care, lack of access to medications, and sensitive personal, financial, and health information is at risk of being exposed and exploited when a cyber attack happens on a healthcare facility. Beyond the immediate impacts and fallout of recent cyber attacks, these incidents underscore ongoing risks that patients bear of having their personal health and financial information compromised. This calls for the need to be proactive at this time to ensure that we have plans centralized and are ready to be better prepared. We think that this bill will help Maine mitigate the harm of cyber attacks and that they cause our healthcare consumers. And for this reason, we do support this bill. I also just want to share the story of one of our volunteers who was directly affected, was actually in hospital at the time and apparently fully transferred out to get the care that he needed because it could no longer be provided. I believe he's writing his testimony. He had to leave early today. Is going to be sending that your way. So please, happy to let you know.
Thank you. Questions from the committee? I'm seeing none. Thank you for being here. Testimony and support here in the room.
I will email my my remarks afterwards. Printer was not agreeing with me. I just put it that way. I love that. I know. It's always on those kind of mornings. Representative Meyer, members of the committee. My name is Marge Kilkelly. I'm here on behalf of Legal Services for Maine Elders. LSE provides free legal help statewide for Mainers age 60 and older when their basic human needs are at stake. Our clients are generally low income, some with medically complex conditions. We are here to support and comment on LD 2103, requiring hospitals to adopt cybersecurity plans. I am certainly not an expert in how cybersecurity plans are put together. And I also feel that one of the challenges we face at this point in time is that people have been robbing banks for hundreds of years and we haven't stopped that. So we probably aren't going to actually stop. But what we need to do, given that, is to make sure that there is a plan in place so that patients can access information, they can continue their treatment, they can get a prescription refilled. I heard a story from one person about not being able to get a prescription refilled unless they had the bottle with them. And these things were all very difficult, and especially difficult for older folks who are not as up to speed on some of the electronic aspects of how things work and can't really quite understand. So as you've heard from previous speakers, it adds to the stress, especially when someone is dealing with a disease issue. So we really urge your diligent work on this, which we know will happen, and to really be aware of the aftercare. And so we can make sure that when and if a cyber breach happens again, that people are going to, within whatever we can do as a reasonable time, make sure that they can access a doctor's office, that they can access the medication they need or get information. So thank you very much. And we really appreciate Representative McCabe bringing this forward. Thank you.
Thank you. Questions from Ms. Kilkelly? Seeing none. Is there anyone else in the room with testimony in support? Let's let Representative, as soon as we're done in the room, we'll go to you and then I'll go to Zoom. Okay.
Oh,
No,
okay.
it's you.
All right, thank you.
Welcome.
Thank you.
Did you have copies of your testimony?
I have submitted email written testimony as well.
Thank you.
Good morning, representatives and members of the committee. My name is Shad Masood. I live in Lewiston, and I'm here in support of LD 2103. I'm speaking today in three capacities, as a hospital employee, as a caregiver, and as a patient of Central Maine Medical Center. I started at Central Maine Medical Center in 2006, and it just so happened that was the summer that the hospital actually went to an electronic health record in the hospital, and I took on a secretary's position, so I actually was kind of bridging the gap between written orders and carbon copies and faxes, and doing a redundant process where I was entering a lot of information into the computer so that we would have that information in years forward, readily available. So, anybody else who's worked in hospitals, we went through reams of paper, and, you could multiply that by hundreds of patients, 24 hours a day. And at that time, the move to electronic systems really felt transformational. Like, we were awaiting this more efficient, largely paperless world where accurate information was entered by the right person at the right time and could be accessed seamlessly by anyone on the care team. And, it was almost going to be like an Olympic relay team, information moving quickly, cleanly, without any friction. And in many ways, a lot of these digital systems have improved care. I want to recognize that. But what the last year has shown us is that when digital infrastructure fails and when redundancy has not been fully maintained, we don't fall back to a smooth relay of information. We fall back to uncertainty. And as a patient during the recent outage, I had difficulty reaching my primary care provider. I had to reschedule. I had to actually physically go to the office, wait in line, schedule a new appointment. And then when I went to that appointment, my doctor didn't have any of my prior records, so I had to educate them about my current status and what I needed help with. And frankly, I have this experience of being a nurse in a hospital system, so I have a little bit more knowledge and jargon, and I can kind of give a nice, concise report to a doctor. I don't think a lot of people have that in their back pocket. From a patient perspective, I didn't know if my messages were being received, if the provider was going to see my chart eventually, and, if my refills were going to be taken care of. And this created some anxiety. I also went to the doctor in the same system with my mother, who also had the same difficulties of reaching them by phone. Finally, we get into the office, and we're there regarding lab results. And I had to actually pull up the lab results on my phone and then show that to the doctor, and basically out of context. We were just kind of, again, sharing what the trends of her lab values were. We were showing this new lab value, and then we were expecting an answer from the doctor, which, they gave an answer, but it didn't really make us feel like they were working with a full deck of cards and understanding of the gravity of the situation. So that was also nerve-wracking. And in that moment, the burden of continuity of care shifted from our institutions, our trusted healthcare institutions, and it fell onto people, the patients and the families, and that was very.
Could I ask you to wrap up
Sorry.
your testimony?
Okay. I want to, as a worker, I wanted to commend my colleagues for responding strongly and as best as they could, but the anatomy of this cyber event did not begin on May 31st. It began years earlier in governance decisions, infrastructure investments, and leadership continuity. And the resilience is cumulative, and our vulnerability is cumulative. So if cyber security intrusions that disrupt patient care are to be treated as patient safety events, I strongly believe they should be, and they should be considered like sentinel events that we already have to report in the system. And patients should not become the backup system. So in resolution, I hope LD 2103 is a necessary step towards treating cybersecurity as what it truly is, a core patient safety obligation.
Thank you. Questions? Yes, Representative Zager.
Thank you very much for being here today. It's always great to hear thoughts of folks who are at the, right at the point of care. Can you describe any recollections you have of what cybersecurity or other things pertaining to that training you have gotten absent this legislation in your system?
Yeah, so I was employee of CMMC for close to 15 years. During orientation, they do go over, for about 15 to 20 minutes, the policy around HIPAA, how to secure your email or how to make sure that you're not sharing PHI information. Over those, 13 years, I was involved in both training nurses around downtime or building downtime packets. It was definitely like a very, I could say, among all the other priorities, it was definitely kind of ad hoc and by the seat of your pants, I would say. So we can definitely make more improvements there. Yeah, and I think there could be, better education, more. I had my orientation 13 years ago, so a lot had changed. If I hadn't been paying attention, I don't know how competent I would have been over those years. So I think annual review or some sort of regular cadence would be helpful for all staff, experienced and new.
Yes, Representative.
Thank you, Madam Chair. From your experience, did your hospital have a joint commission review?
Ever or
Ever
after
in
this
the
incident?
years of service that you had at that hospital? Were you familiar with any?
Oh, yes. Yeah, we've had many joint commission reviews
And-
and accreditation audits.
And was there any query into emergency preparedness during that review process? Nothing that you were aware of?
I would imagine there
no.
is the standard emergency preparedness. I don't know how in depth they go around cybersecurity or analyzing a cybersecurity plan in those audits or accreditation reviews.
Thank you.
Seeing no other questions, thank you for being here today.
Thank you for your time.
Anyone else in the room with testimony and support? Representative? And then we'll go to Zoom for testimony and support.
Representative Meyer and members of the Health and Human Services Committee. My name is Michelle Boyer and I represent House District 123, which includes the town of Cape Elizabeth. I'm pleased to testify in support of LD 2103, an act requiring hospitals to adopt cybersecurity plans. I want to thank the bill sponsor, Representative McCabe, for bringing this measure forward. After a series of cybersecurity attacks on hospitals in Maine this past summer, including Central Maine Medical Center, St. Mary's Health, and St. Joseph Healthcare, it has become evident that Maine needs a standardized emergency response protocol for patients in the event of any future data breaches. This bill creates a contingency plan in the event of future data security breaches on the digital infrastructure that supports hospital systems throughout the state. It reinforces the need for hospitals to establish regional mutual aid partnerships, outlining that if one hospital experiences a cyber attack and cannot operate fully, nearby hospitals are prepared to receive impacted patients as capacity allows to ensure continuity of care. The American Hospital Association, a national organization representing hospitals, published an article citing the ways in which cyber threats put patient safety at risk. Healthcare organizations like hospitals have valuable information that makes them particularly vulnerable to attack. This same article further highlights that the cost to remediate a breach in healthcare is almost 3 times that of other industries. LD 2103 will ensure that in the event of a breach of a hospital system's cybersecurity, the facility will have a developed plan to address any displaced patients and the ability to provide and maintain uninterrupted care, such as helping patients access transportation if they are unable to use their typical local provider. Additionally, this measure encourages hospitals to leverage existing resources, such as the Center of Disease Control's Medical Response Team, which can be activated during emergencies to help alleviate strain on an affected healthcare system. The introduction of this measure reflects that we live in an ever-evolving, increasingly digitized world. By establishing a standard response protocol for future cybersecurity attacks, we are adding another safeguard for patients and ensuring continuity of care. Thank you so much. Happy
Thank
to
you,
try and answer
Representative Boyer. Questions from the committee? I'm seeing none. Thanks for being here
Thank you all
today.
so much.
You want to bring over a couple of the Zoom in favor folks? Welcome.
Thank you.
We're running a 3-minute clock. I'll give you a little nudge if you get close.
Understood. Hello, everyone, and Representative Mayor and distinguished members of Health and Human Services Committee. I am Dr. Cassie Dove, professor at University of Southern Maine in cybersecurity, as well as a resident of Baldwin, Maine, and a U.S. veteran of the U.S. Coast Guard. A few weeks ago, Representative McCabe and I discussed with a few other members what happened in Lewiston and at the Central Maine Medical Center last year. Unfortunately, I was one of those patients at the emergency room after a fall, and I was unable to obtain an MRI. Well, this was not life or death. We had to move to another facility much farther from home. And in addition, there was no way for hospital personnel to obtain any previous information on my visits or health issues. As a disabled veteran, this can be distressing, as I know Central Maine Medical Center can view veterans' files and vice versa. Many other hospitals don't have that access, so not everyone is able to travel further distances away from their local medical institutions and to receive that necessary care. While I was able to do so, hospitals do need plans in place to ensure patients are able to access both healthcare and the transportation to get there when they're unable to provide it due to down systems. I was informed by medical personnel that there was no previous access to records for the entire month between June and July of 2025. The CMCC and its other healthcare institutions also did not have access for those patients during that outage. While that problem is well known, CMC had the issue with their patient's record being exposed and instead chose to shut down the entire patient network to protect other information from being leaked further. Letters were sent to patients in the network, and they were told that CMMC was doing everything it could to protect patients' information. As a cybersecurity professional and master's level instructor at the University of Southern Maine, this is one of those scenarios that's very dangerous, and we dread every day as CS professionals. While many institutions have cyber education for new employer hires, there needs to be more training for employees every year in the healthcare institutions. All people who use the electronic healthcare systems for patient care, including their other providers, and we all need to be educated on how to manage patient records securely, especially after a cybersecurity breach, like the one that happened at CMCC last year. Not only does this need to take training and needs to be yearly for all personnel involved, but there needs to be a solid backup system and plan so healthcare professionals can access patients' data without putting their workstations at risk. This type of system needs to be a standalone system that will not tie into the mainframe, that it may be exposed until restoration is completed, but give access so the doctors and the patients can have access to their files. Lessons learned should be shared and all actions should be reported to all the shareholders as well as the patients, and they all understand the records are now safe and no longer exposed to unethical personnel. A cybersecurity plan, which I teach every day on the master's and the undergrad level, is essential for medical centers and doctors and everybody involved, as well as all audits performed to ensure pen testing, security protocols, as well as training is performed annually as described in LD 2103. And of course, I support LD 2103. Thank you for your time and any questions.
Thank you for being here. Questions from the committee? Yes, Representative Daigle.
Thank you for your presentation. Have there been any files that you know that were irretrievably lost?
Not the problem with this type of investigation is nobody really sincerely knows all the files that were lost. They were inaccessible during those one solid month. So while patients may have been taken care of and things were written down on paper. We don't know if everything was filtrated back in the system and what happened to the data that was taken during the outage and what happened to the data that was taken before. But we're not aware of any lost files.
Representative Zager and then Graham.
I don't know why I'm having trouble with my butt today. Forgive me, Madam Chair. Professor Dove, thank you very much. I appreciate your service in the Coast Guard years previously. Why do you suppose there is such an increase in cyber attacks on hospitals and healthcare facilities in the last few years?
Well, it's interesting, you know, and I was talking to Representative McCabe about this. You can walk into a patient's, office or doctor's office, and the doctor will actually physically take out their cell phone to record their transcripts. Right? This is a problem. We have so many security protocol issues, and because everybody's so used to having their own personal information and their own personal technology, and that's, years ago we didn't have that. So we're seeing it more and more because no matter what you do, if I'm sitting next to somebody and 6 feet from them, they have their cell phone, I can actually copy their entire cell phone if I know what I'm doing. And there's your patient data.
So you're saying that it's that there are vulnerabilities that have become that have occurred in the last few years, and therefore people can exploit those vulnerabilities.
Absolutely. And the biggest thing about, the transcription services, and this is what I hope to research this summer with what's going on with transcribing in the state of Maine, is, they are using their personal cell phones and they're taking those cell phones home, and there's a security protocol issue there. So there's all kinds of things. And that's just the tip of the iceberg. We need to, like we would say in the military, batten down our hatches, make sure that whatever happens in that office during that visit is secure and happens on a station that there's no access or vulnerability issues, because someone can go in and tap into and get all that data.
All right. Well, thank you so much.
I hope I'm very geeky, so I'm sorry.
Geeky is welcome.
Professor Grove, thank you very much, Dove, for this. My question is, so you said you teach in the master's program and the undergraduate program of the nursing program?
No, I'm in Department of Technology, and I am the cybersecurity professor. So I teach cyber law and ethics. I teach cybersecurity laws and project management, which is just what this bill is going to need, how to map out that cyber, emergency management plan and stuff. So this is what I'm teaching our master level graduate students, exactly what to prevent.
So my question is, wouldn't it be appropriate for undergraduate nurses and docs and anybody that's going to be in the healthcare system, because this is clearly impacting the healthcare system. So I'm glad you're doing that for cybersecurity experts, but how do we integrate that in? I mean, I recall when I basically retired from clinical practice in 2010, and we were just moving into electronic records. So that's a suggestion, and that I wonder if that happens anywhere in the state and in the country where we can integrate some of this in, because clearly when people get into hospital systems, they've got to know how to do this.
And that's very correct. If anybody wants to write a letter to President Edmundston at USM, that would be greatly appreciated this time. It's hard to map that. We teach cybersecurity, but I do get a lot of students that want to go into cyber and healthcare. So I get that. But as far as like your average cybersecurity person has been a computer science person, and the degree is so brand new that we're not sure if we can get that minor into a nursing program and stuff like that, because they're all so concentrated on what they're learning. So I think in the next 5 years, we'll see a change and we'll see an overlap. But right now, nobody's doing it.
You have a question, Representative? Yes.
Another question is, I'm dentist by trade, and we switched to electronic records. And in the practice, using a cell phone or anything other than the laptops that were there was forbidden completely. And if we did that, we were in some trouble. How widespread is the use of these devices as far as like transcribing or accessing notes?
I just saw it 2 weeks ago when I went in for an appointment through the VA, not the VA, but Maine Medical. And so if I'm seeing it as a regular patient and I ask my doctor directly, are you recording our visit on your personal cell phone and what happens to that data? And she goes, oh, it's all safe. We were told it's all safe and it gets transcribed. And I said, but what happens to that data when you go home with your cell phone? She didn't know. And so they're not being educated and they're being told by transcription services that they can use their personal devices and then transcribe it and send it to the transcription services to save them time and money.
Thank you. Thank you. Thank you for being here.
You bet.
Appreciate it. Moving on, is it Mr. I got to put my glasses on. Dameth? How'd I do?
Thank you very much. That was a fantastic pronunciation. Thank you.
Excellent. Go ahead. You can get started. We're running a
Thank you.
3-minute clock.
Wonderful. Distinguished members of this committee, thank you for this opportunity to testify today about the cyber threats disrupting our country's healthcare. And I am speaking in support of this bill. My name is Dr. Christian Dameth, and I'm a practicing physician. I train students, resident doctors, as an associate professor of emergency medicine at the University of California, San Diego. I'm a little different than your typical emergency medicine doc, however. I'm also an ethical hacker and considered a global expert on healthcare ransomware. I now conduct research on the patient safety impacts of cyber attacks as co-director of the UC San Diego Center for Healthcare Cybersecurity. As we've heard today, ransomware and other cyber threats spread across hospital networks, and the likelihood of chaos skyrockets. When doctors and nurses are not able to utilize computers and medical technology, patient care suffers. A growing body of literature highlights the damaging effects of ransomware that extend beyond data breaches. Our research at the center has demonstrated huge spikes in emergency department patient volumes, prolonged wait times, record high ambulance diversions, and worse outcomes from cardiac arrest when ransomware occurs, just as you experienced in your own state during your last attacks. The simple reason for this is that healthcare is increasingly dependent on critical connected technologies to provide care. When patients are fighting deadly infections, hemorrhaging from trauma, or suffering from massive heart attacks, minutes, sometimes seconds, matter. When doctors and nurses are not able to access this technology, patients are harmed or die. Healthcare delivery organizations face incredible pressures that disincentivize transparency during cyber attacks. While hospitals are required to have emergency operation plans for disaster situations, many have generic downtime procedures which are not optimized for cyber attacks like ransomware. These plans are infrequently tested or refined, and many hospitals have no cyber attack specific plans at all. The costs are huge. Healthcare was noted in many industry reports to be the costliest ransomware impacts, with average costs double or triple the second-rate sector. Scripps Healthcare reported an operational loss of over $100 million stemming from a ransomware attack in May of 2021 that was associated with over a month of system downtime. This scale of financial impact can be devastating to many smaller, rural, or critical access hospitals running thin margins with little cash reserves. In conclusion, cyber criminals threaten our ability to deliver care for our patients when it matters most, but we can make progress on this pressing challenge. I applaud this committee's leadership on this critical issue, and I am optimistic that we can improve cyber resiliency in healthcare by passing this bill, and sincerely thank you for the opportunity to share my perspective and open to answer any questions you may have of me.
Well, thank you for being here. Questions for Dr. Dameth? Yes, Dr. Zager.
Thank you, Dr. Dameth. The bill brings up, a really important issue about cybersecurity. And a previous testifier, I'm not sure if you were online or could hear, but she was also a cybersecurity expert, and she described a situation, where people's mobile phones, that even if not transmitting, could be it can be hacked from 6 feet away. There are, in your practice in the emergency room, you might have applications that have to be there at the point of care. For instance, to send an electronic prescription, sometimes you need a PIN that needs to be generated, and those are only available on the mobile phones. So how do hospitals around the country deal with that difficult spot where you have to have a device, but that device also can open a vulnerability to be hacked?
That's a fantastic question. I would separate these two issues a little bit. The first, there are vulnerabilities in devices like mobile phones and applications that we need to communicate. You mentioned a few. Those are important. Those are not necessarily unique to healthcare and are unlikely to change anytime soon. To my knowledge, and there is no definitive study on this, the way that cyber criminals are attacking hospitals is not often through cell phones. It's not often through these types of applications. It's often through what ends up being very poor cybersecurity practices at the periphery of a hospital. And they couple those attacks with what are called social engineering attacks. These are when they try to trick you into giving over your password. They try to pretend to be your boss. They send you an email, a text message, try to gain your trust, and then trick users that have privileged access, have passwords and usernames that can give them access to tricking them to giving those over. Then criminals get into these hospital networks. They take about a week or two or sometimes more to find out what they have. They'll go and pre-deploy all the malware in the hospital. They're going to figure out how much they can extort the hospital from, and then they will execute their malware. To my knowledge, I'm not aware of a vulnerability in a mobile device that has resulted in a hospital ransomware attack. I'm not saying it's not happened, but at least not publicly reported. I have heard of dozens of ransomware attacks that involve poor, outdated security practices and patching and social engineering attacks. But it does not necessarily detract from the importance that you bring up, which is that just adds to the vulnerability. I would say this is one of many vulnerabilities that hospitals have, and ones that we need to take into consideration, prepare for. And as was mentioned by an earlier speaker, there have been bank robberies for as long as we can remember. There were banks. We haven't prevented all of those. There will be continued vulnerabilities. We need to prepare for the impact that these have, lessen them, and we can do a lot of that by these provisions in this bill.
Appreciate it. Thank you.
See no other questions. We appreciate you being here today. Ms. Crowley, welcome.
Thank you.
You can get
Good afternoon, Representative Mayor and honorable members of the Health and Human Services Committee. My name is Janelle Crowley, and I've been a registered nurse for 16 years. I currently work at Maine Medical Center as a NICU nurse, and I'm a member of the Maine State Nurses Association. I'm testifying in support of LD 2103 as amended by Representative McCabe's sponsors amendment. Hospitals are increasingly targeted by cyber attacks like the attacks that affected 2 Maine hospitals this past year. This bill will help ensure that all Maine hospitals are prepared to defend against cyber attacks and to safely provide patient care if an attack does take down key electronic systems. My union nurse colleagues in other states faced a particularly severe challenge in 2024 when a cyber attack left Ascension Health System hospitals without key electronic systems for a month. That attack took down computers nurses relied on for patient care basics, like ordering food, getting test results, fulfilling and administering prescriptions, paging staff for codes, and charting in electronic health records. Those hospitals were not prepared. Experienced nurses stepped up to train younger nurses on paper charting on the fly. Basic patient care tasks were hugely impacted. Everything from lab results to pharmacy orders to patient discharges were delayed as nurses picked up the slack created down by the down systems and patients noticed. Despite the chaos, many elective procedures were not canceled. Communication from management on how to handle basic tasks were inconsistent and changed frequently. We want to make sure that every Maine hospital is prepared for a cyber attack or other emergency that takes down electronic systems. Right now, we are not. My hospital is not doing electronic health records downtime drills or training nurses on the skills needed to care for patients without electronic systems. I don't know what the plan is if the system goes down. This bill as amended will require hospitals to consult with workers and our unions to create a plan so that all of us working at the bedside can identify what we need to care for our patients safely. We'll know in advance how the hospital will manage triage, diversion, cancellation of elective procedures, communications, and anything else necessary to make sure our patients are safe when the computers are down. Crucially, the bill also requires that all employees who use electronic health record systems for patient care are trained on the skills they need when the systems are down, and that hospitals complete an annual test run on all shifts and units, so whenever an emergency happens, we are prepared. Thank you to Representative McCabe and this committee for addressing this urgent issue, and we ask for your support on this bill.
Thank you. Thank you for being here today. Questions? I wonder how receptive is the leadership at the hospital you're employed at to the concerns that have been raised by the nurses regarding the lack of a plan?
We're having an open dialogue right now. They do seem to be fairly receptive, but that's only within the union hospitals. And we have a lot of non-union hospitals. And so that's kind of where this bill would help fill in, is where we don't have as open a dialogue and representation from the nurses with leadership.
Thank you. Appreciate you being here today. Anyone else? Yep. Welcome.
Hi, thank you. Sorry, my screen just got rid of my testimony. All right. So Senator Ingerson, Representative Meyer, and esteemed members of the HHS committee. My name is Mariah Pfeiffer. I work as an RN in labor and delivery at Central Maine Medical Center. And of course, I'm here, as on my own accord, not as a representative of the organization. But I wanted to share a little bit about my experience during the downtime after the cyber attack and the impact it's had on our community and also on our state. I've been a nurse for 15 years, and I still get a little anxious walking into the hospital doors just because you never know what is going to greet you that day. But when I walked in shortly after the downtime, it felt triply that way. When all the systems we depend on aren't working, you just feel like the ground beneath you isn't stable anymore. Most nurses have never experienced downtime or have only experienced it for an hour or two, and when it has been planned ahead of time, so we were prepared for it. During the downtime, staff and providers frequently expressed that it felt like working during COVID all over again, that same level of confusion, of working harder and have to invent new workarounds and systems to complete the same work we always do, and not knowing when that environment is going to end. It's incredibly stressful. Downtime also brought up a number of safety concerns for us in particular. In labor and delivery, we rely heavily on electronic fetal monitoring. And normally you can see it both in patient rooms and out in the nurse's station and all of the physician computers and provider computers. But when that's not functioning as the nurse in the patient room, you're stuck in the room, first of all, and so you're spending 12 hours in there, and you're the only one seeing the patient's fetal monitoring, and it makes it much more difficult to have the collaborative care that we rely on for patient safety. Much like the emergency room, patients in L&D arrive unannounced and oftentimes so uncomfortable that you have little time to ask questions and get a full medical history. And we really didn't have full medical history from looking at Health InfoNet. So, and finally, patient records from the downtime were scanned into patient charts after the fact, but scanning records in was an incredibly slow process. And oftentimes our newborns were being seen at pediatric practices without having an available medical record because it hadn't been scanned in yet, which created more risk on the pediatric end of care. And as a community, I'll just add that patients really took note of this downtime and some transferred to other hospitals. We really lost the trust of our community. And on top of that, we were initially told that the impact wasn't very large, maybe a few thousand people. But lately, we've been told that downtime at both Lewiston and Auburn healthcare institutions affected over 1/3 of the state's population. So this wasn't just a minor breach. This is going to have lasting statewide impacts. And mostly we felt alone during this experience. It felt like the rest of the state left it up to us to deal with it on our own and that we had no information about what was actually going on while it was happening or after the fact. Having systems and a plan in place to help support hospitals and staff experiencing these attacks and to better communicate with the public will bolster community trust and help avoid another experience like the one we endured. I urge you to support LD 2013 so we work together as a state to support our healthcare systems because it's what Mainers deserve. Thank you.
Thank you. Questions from the committee? I wonder what sort of changes you've seen instituted within the hospital that you're employed at since the cyber attack. Have there been any changes that have that would have addressed any future vulnerability now that they've experienced what can happen?
Honestly, none to my knowledge. And, maybe I'm not involved in that level of conversation as a staff nurse, but you'd think that we would be a priority audience for that level of conversation.
Thank you. Appreciate you being here today.
Thank you.
That's all for support. Okay. Anybody else in the room in support? So we'll go to testimony in opposition. Why don't you bring the one person that's on Zoom so that they're not waiting? Jeff, we're going to take the one person on Zoom. Yeah, and we'll take you first. Welcome.
Can you hear me?
We can hear you. Yes, we're running a 3-minute clock.
I've got it.
Okay.
Representative Meyer and distinguished members of the Committee on Health and Human Services, my name is Wynn Brown, and I'm the president of St. Mary's Health System in Lewiston, and I'm here to express opposition to LD 2103. Before I begin, I do wish to thank Representative McCabe for bringing to attention this important matter in the meeting with us. She met with us earlier to discuss her initial draft and experience with Covenant Hospitals of Maine in confronting issues as those that this bill is trying to address. We appreciate the spirit in which Representative McCabe brings this proposed legislation forward out of concern for her constituents and the continuity and quality of health care they receive, concerns which we always have foremost in the minds of the Covenant as well. We oppose this bill only because we respectfully submit that it would, at a practical level, impose new administrative costs and uncertainty without advancing the underlying objective of protecting patients. Last year, Memorial Day weekend, our health system was victim to a cyber attack. To protect our patients and their data, we immediately turned off our electronic medical record and switched over to paper charting. Our staff were trained ahead of time to do this, and they did it well, although I will say it did take a little bit to get a rhythm to it. Over the course of 2 weeks, we worked to eliminate the threat from our system, and we were able to turn our electronic medical record back on 14 days after the attack happened. First and foremost, during the attack, we were focused on our patients. As a result, our patients were able to access information, access care, keep their appointments or have their appointments rescheduled, get necessary referrals, and have prescriptions refilled. I will also just note, it's not in my testimony, but at the same time, a couple of our local pharmacies' electronic systems were down as well, which exacerbated it for everybody to get their prescriptions refilled. We continue to provide care, phone lines and facilities remained open, and staff communicated with patients to coordinate care. That said, the cyber incident was incredibly disruptive, and there's absolutely no doubt about that. Responding required a tremendous amount of staff time, expensive consultants, anxiety and stress. It was definitely challenging for patients as well. Every day we work 24/7 to resolve the problem, always the focus on our patients and our staff. So if there's anybody here who would like to see the likelihood of a cyber event reduced to zero, it's me. The thing is, we at St. Mary's and our parent organization Covenant took all the protective planning measures required by existing federal law prior to our cybersecurity incident, and the attack still took place. We did these things because they are already required by federal law, and we believe they were the right things to do. Simply put, HIPAA already requires hospitals to have in place stringent administrative, technical, and physical security guards to ensure confidentiality, integrity, and availability of all electronic protected health information that's covered by the hospital, creates and receives and maintains and transmits. I'm just reading from what it requires. and to protect against any reasonably anticipated threats or hazards to security or integrity of such information, to protect against any reasonably anticipated uses or disclosures of such information that are not permitted or required under HIPAA, and to ensure client
Mr. Brown,
compliance. Yes,
would you be so kind as to wrap your testimony up, please?
I will. I'm in my home stretch,
Excellent.
winding it up. So what we're saying is that while this is well intended, it really is duplicative of what they're asking for, or in conflict with the federal regulations that we already follow. And there's some things in the proposed legislation, like being able to provide, while you're in the midst of a cybersecurity attack, to produce a printed record for someone that day upon request. That just isn't possible when your electronic record is shut down. So there are several things that just make it very difficult, but really it is largely duplicative, or the language is in conflict. So it's actually more confusing and duplicative for what we have to do as an organization. So I'm happy to take any questions, as I know that I've run over my time, and respond to any queries you might have.
Certainly. Questions from the committee? Seeing none, thank you for being here today.
Thank you.
Testimony in opposition here in the room? Mr. Austin?
Representative Meyer, members of the committee, my name is Jeff Austin. I'm here on behalf of the Maine Hospital Association to speak in opposition to the bill. I too want to thank Representative McCabe for reaching out. She did reach out to hospital representatives ahead of time, and we appreciate that. Not everybody has the time or the willingness to do that, and she did. The primary message from our members when they discuss this bill is that they are really trying, that this is not something not on their radar screens, that they are very well aware of the risks, and that they are doing what they can. One thing you have not, they all said they had cybersecurity plans. One thing you have not heard about, I don't think yet today, is they all also carry cybersecurity insurance. And when a third party agrees to take on financial risk, they are in a position to ask you, and they tell you what to do in order to preserve that coverage. Much of our protocols is somewhat dictated by those who are willing to take on financial risk. The state is not taking on financial risk here, but is wanting to have the authority to tell us how to respond to these incidents. Furthermore, the other thing you haven't heard a lot about, I don't think yet, is the heavy presence of law enforcement. The FBI can come in and sort of dictate to you what you will and will not do, what you will and will not say. You have third parties that have big interests in the outcome of these events, and we have to respect those third parties as well. The state, to our knowledge, is not really, and DHHS in particular, is not broadly involved in cybersecurity. We're not sure that an additional state mandate to what exists federally with law enforcement and with insurance policy requirements is going to solve the problems. A cyber attack is a crime. The hospitals are victims of a crime. There will be disruption. Many of the disruptions that you heard about today from some of the proponents, they're real and they're difficult to deal with. But some of them are not for lack of a plan. Some of them are the plan. Some of them are, yes, you have to get a paper script. Yes, you have to be transferred out of the hospital because the medical device you rely on doesn't exist anymore in this facility. Yes, you have to go to Portland instead of staying in Lewiston. Those are the plans. It is disruptive, but those don't go away with a new mandate to have a plan. That's the implementation of the plan. It's a hardship, but that is part of the plan when, as you've heard, the devices are not available. I won't recite what's on page 2 of my testimony. That's a lot of the federal law. The only thing, if you do look at it, I would ask you to look at it, that I would ask you to note, multiple of them are under revision now. This is not something the federal government is just sitting on 30-year-old law. Multiples of these things are in process now. I have one last page on LD 2103. I'm the only one in the room to be speaking today, but I'm out of time. So with your indulgence, I'd like to cover some of the particulars of the bill, but otherwise, I'd be happy to take questions.
1 minute.
Thank you. First, this is an expensive unfunded mandate. There are a number of annual test runs, tabletops, annual trainings. We have about 50,000 employees. 1 hour. That's 50,000 FTE hours that would have to be paid per year. There is no funding in this bill. There's no funding coming from Medicaid to cover Medicaid's costs. The costs of the bill would have to be found elsewhere to make typically commercial insurance. Other mandates, as you've heard from Mr. Dodge, same-day medical records, printed medical records when the computer that contains the record is down would be impossible. Transportation, we have to insure transportation for up to 400,000 people, as you heard, with one breach. We're not transportation logistics experts. We don't do transportation for people. We can handle the patients in our facilities, getting them to and from, but transportation for a private citizen to get to a pharmacy seems a bit much for us. We think it is very unwise to submit some of this stuff to the department. They want annual audits and the results of those audits submitted to the state. The result of an audit is, here's a weakness. Here's something you should do differently. Don't do that. I don't think you want 35 hospitals with their weaknesses compiled in one state repository. That becomes a risk itself. I will wrap, and I appreciate the extra time. The Lewiston folks bore the brunt of 2 attacks. Disruptions are going to occur. These hacks have consequences. Our members are trying their best. They are doing plans. They are taking insurance. They are coordinating. I gave for you Mike Tyson's famous quote. Everybody has a plan for what they're going to do until they get punched. Lewiston got punched. They implemented the plans as best they could, but it is hard. And some of the planning involves disruption. You may have to go here or travel or pick up. It's hard, but our members are the victims of crimes and they're trying their best in these really trying circumstances. Again, we certainly appreciate the spirit in which the bill was offered, but we don't know that an additional layer of regulation is going to help.
Thank you, Jeff.
I appreciate your
Yep,
indulgence.
questions from the committee, from Mr. Austin? Yes.
Thank you, Madam Chair. Thank you, Mr. Austin. So I'm hearing about this very horrific event and it's very troubling, just as a troubling event. So what I'd like to know are what safeguards do we have in place right now? And you've also referenced the Joint Commission. Are all the hospitals under a Joint Commission survey process?
Well, to be clear for the committee, so Joint Commission, you have to follow federal regs.
Yep.
Many times the enforcer of those federal regs is the Joint Commission. I think most of our hospitals are at this point Joint Commission regulated, but if they are not Joint Commission, they are either state or another party. So everyone is subject to some sort of audit.
Well, maybe a different question then. You referenced that all hospitals have a plan. So if every hospital has an emergency management plan, is it reviewed annually, biannually, every 5 years, self-imposed review process? What?
Internal review?
Yes.
I would have to ask each
So
hospital
you
how
don't know.
frequently they
Yes,
do that.
okay. So
But I could.
I'm just getting a sense that some hospitals may be stronger in this area of emergency preparedness than another. And I wondered,
I think that's probably fair to say.
that's fair to say. I guess for the work session, I'd like to know that answer in some way, because if we have great vulnerabilities in some hospitals, then maybe statute legislation is required. But if we have a strength, some uniformity in how they're looking at themselves for emergency preparedness for all things, natural disasters, biologic, cyber, everything. And
Well,
otherwise we'll go, I see it as a real need.
let me briefly respond to that. I think the professor from California talked about that. It's not optimized, I think was the word he used, to cybersecurity. And for what you just said is why, right? You can have mass casualty, you can have an earthquake, you could have a biological event. There's all kinds of things that the emergency preparedness plan requires you to, sorry to turn my back, be prepared for. And it depends on what the nature of the disruption is. They can be very different. It can be hyper localized just to your hospital. It can be across your entire county. So a lot of the emergency preparedness, you could have trainings all the time for the variables of events that could possibly occur.
Can I just follow up?
Sure.
So to narrow my request for the work session, I guess relative to cyber attacks, what's the lowest benchmark for uniformity? All hospitals do what kind of a
Well,
preparedness for cyber attacks? If you're able to get that answer,
I will do the best I can
You'll
to,
get a blue
to be
ribbon.
argumentative a little bit. The uniformity that's in place now is under federal law and it's
Oh, that's it.
nationwide. And you can train with national experts because they're all operating, again, I'm sorry, I'm turning my back, from the federal standards that are out there. Once Maine begins to deviate, and we've seen this with like the privacy law, once you begin to deviate, you have to caveat your trainings and your national experts have to say, well, in Maine, it might be a little different. So the uniformity you're searching for does exist at the federal level in the menu of laws that are out there. But even they are changing their laws, as I said. I mean, multiple of them are under revision right now. So I know it's not appealing for a state legislature to hear because you want to solve the constituents' concerns. But once you start to deviate federally, those trainings and those national experts and those lessons learned in other states, you weaken it a little bit. I don't want to overstate the case, but you do sacrifice some uniformity when you go at it at a state level.
Thank you for being here today.
Thank you.
Testimony neither for nor against.
I'm sorry, my testimony is in opposition.
Oh, okay. I'm sorry. Mr. Austin indicated he
that,
was
and
the
I-
only
I
one
may
here
have
in
been-
opposition.
I may have been unclear when we talked, and I apologize.
Not a
Uh,
problem at all, Mr. Dingman.
Thank you. Thank you. Good afternoon. Representative Meyer, distinguished members of the Health and Human Services Committee. My name is Charlie Dingman. I'm a lawyer with the firm of Kozak and Geyer. Our focus is healthcare law. And I'm here today representing Covenant Health. You've already heard from Wynn Brown, the president of St. Mary's. I'm here just to supplement that testimony with some legal analysis. And I want to echo Wynn's appreciation for the approach that Representative McCabe has taken to this problem and the diligence with which she has sought out a variety of opinions on the subject and has been willing to interact with all of the affected parties. We do not at this point feel that the bill as redrafted over the weekend achieves an improvement in the legal framework that is already available to address these issues. And we feel that it does raise a number of concerns where it either conflicts with or deviates in ways that aren't clear from the HIPAA, not only the HIPAA rules, but also existing state law dealing with cybersecurity. I don't want to try to go into that in detail now. Attached to my testimony is a document prepared by one of my colleagues at Kozak and Geyer, who has worked in privacy and security issues for most of his career and has much more understanding of this than I do. And what you will see there is a table that compares the proposals in this bill in its current form with existing law, both federal law and state law, and a long series of comments on what the concerns are in each of those instances. And I would urge the committee, if you do go forward with legislation in this area, to take give careful attention to that the potential for overlap and the potential for requirements that may not even be helpful in the final analysis. And that includes, for example, the potential that filing certain plans that are now required to be filed with HIPAA, with the Office of Civil Rights, which oversees HIPAA, would be filed here in Maine without clarity about their confidentiality. And having those cybersecurity plans public could pose its own troubling risks for the hospitals that are trying to maintain security. One other thing I'd like to do is respond to a question that was posed earlier, and that is to just point out that the current requirement with regard to the frequency of updating cybersecurity plans under HIPAA is that it be done periodically. It does not say annually, and HIPAA, in fact, intends that flexibility. There may be times when changes in the environment or events that occur, such as a cyber attack, might require more frequent than annual updates. There are other times when an annual interval might not be particularly helpful. And I'd be happy to respond to any questions.
Thank you. Questions from the committee? Do we have any idea of what is underway at the federal level with regard to changes in the federal laws around
I
what's
do
required?
not personally have a good grasp on, they are extensive changes, and I know Representative McCabe has thought about that and has considered those changes as well. For the work session, I could provide a little more information about that.
Thank you. Seeing no other questions.
Thank you.
Anyone else in the room with testimony in opposition? Testimony neither for nor against. Do you have copies?
I don't.
Okay.
It's going to be pretty short.
Okay.
Representative Meyer, members of the Health and Human Services Committee, my name is Dan Walker. I'm with Preddy Flaherty, and I'm here today representing Palo Alto Networks, which is a large global cybersecurity leader, providing network, cloud, and security operation platforms internationally. When last summer, when this arose, we saw the article in the newspaper or online, and reached out to Representative McCabe and offered Palo Alto as a resource. And so we sat down, we had a couple meetings, and provided just whatever assistance we could just to help understand the issue, and helped develop the early stages of the development of this bill. So we just want to put ourselves out there and provide Palo Alto as a resource to this committee. If you have any questions, I can bring them back, or we can be available at the work session on these cybersecurity issues. So I'll leave it at that.
Thank you, Mr. Walker. Questions from the committee? Yes, Representative Graham.
Thank you, Dan. Yeah, I wanted, if you could provide at the work session, I was going to ask our analysts to do this, but what other states have done in relation to cybersecurity in their hospitals, or whether, or the other piece would be our individual hospitals and hospital systems doing it, but our states actually mandating it. It's
Got it.
Representative Daigle.
I'm correct in assuming that it's impossible to prevent the breach of the hack because these people are talented. Is there a way that we could maybe quicken our response to it and ability to get back online?
I'll ask them. I mean, that's exactly the types of things that they are expert at and that they advise on. So I will provide some answers to that.
Seeing no other questions. Thank you for
Okay,
being here.
thank you.
Anyone else testimony neither for nor against? Anybody else online? Okay, so, Director Monteo.
Sorry, just doing research.
No, yeah. You got it, my friend.
I'm more for. Representative Myers, members of the Health and Human Services Committee, I'm Bill Monteo, the Director of Licensing within DHHS, testifying neither for nor against this bill. But I will share with you that, actually, let me start by saying, given federal regulations require hospitals to develop emergency plans from an all hazards approach, as you've heard previously. This bill will establish some specific requirements for cybersecurity emergency planning, and it articulates minimum criteria to be included in the plan. Requires the plan to be updated and submitted to the department on an annual basis, and requires the department to develop rules. Given the increased occurrences of these events, the department supports the bill's intent. And we hope to continue working with the sponsor and stakeholders on amendments. For example, we would submit that the bill be amended to require hospitals provide the plan immediately upon request and not submit them to the department for some of the same concerns that you've heard previously. We would also ask that the change in the requirement be for an annual update, from an annual update to more of an annual review, and require that the hospital conduct a post-incident review of any cybersecurity incident that actually occurred to evaluate the plan's effectiveness in areas that need revised improvement or update, and that the hospital completes and updates the plan timely after such a review. Lastly, we look at amending Section 2B6 to waive the required exercise if the hospital actually experienced a cyber incident and utilized its plan and conducted a post-review analysis, because that is in fact an exercise of the plan. I will also share with you in response to some of the questions that came earlier. All but one main hospital are Joint Commission accredited, but only one critical access hospital is accredited. The accreditation organization does look at compliance with CMS standards, but they're not looking at HIPAA. They're not looking at cybersecurity. They're looking at, did the hospital conduct a risk assessment and develop an all hazards emergency plan? The exercising of those plans does not have to require that the hospital exercise every part of that plan. So you could have a hospital that simply exercises a major trauma incident jointly with their local fire department, emergency management officials, and never actually does a cybersecurity review for 20 years, and they would still be in compliance with CMS requirements that they have a plan and that they've exercised part of that plan. This plan, this bill actually drills down and makes things a little more specific.
Thank you for clarifying that, because I think some of what's been said about the federal regs suggested that they were perhaps even specific to cybersecurity. But we're saying it's an all hazard, so a terrorist attack, a hurricane.
Yeah, when you're talking federal regs, I mean, as was mentioned earlier, the HIPAA requirements may be specific.
Yeah.
But HIPAA is not subject to my office's review. We're looking at
Yeah.
the CMS conditions of participation.
Yeah.
And really the emergency plan is based on the hospital's risk assessment. So if the hospital's risk assessment doesn't identify this as a risk, there's no requirement that they have a plan.
Right. Questions for Director Monteo from anyone on the committee? I'm seeing none. Thank you. Anyone else with any testimony at all? Okay. With that, I will close the public hearing and ask the committee if they've got requests for additional information from our analyst for the work session. Yes.
Because I know I asked Mr. Walker to provide information, but if the analyst can look at what other states have done in relation to cybersecurity, that would be helpful.
Okay, so can we take 5 minutes before we get into the supplemental budget? Or first pass through the supplemental budget, so 5 minutes. Welcome back. We are joined by our analyst, Ookla analyst, Sam Seneft, and we're going to begin to make our way through the HHS portion of the supplemental budget. Try and make a first pass through, and any questions or requests for additional information will be noted, and that information brought back to us for our ongoing work on the supplemental budget. So I'll hand it over to you, Sam.
Sure. So let me orient you to what you have in front of you. You have the green document. Rob asked if it actually needed to be green. I said, yes, it needs to be green. So it is green.
And this is really green.
It is real. I think.
Here we are.
Yes, you won't miss it. So the green document lists all the language from Part A and also from some of that Part T, which is the rainy day fund appropriations. You also have in front of you the purple sheet, which lists the language sections. So we'll go through that too. And Rob gave you a document that lists the FMAP for each of the states. You often ask about FMAP as we go through the budget every year, as well as how FMAP is calculated, because somebody always asks that and we always say, it's complicated, we'll bring it back to you, but Rob wrote it down for you in advance this time. And you also have from Jeff Austin from the Maine Hospital Association written answers to the questions that were asked of them during the public hearing. So what I'm going to do is to go through each of the initiatives on the green sheet, and then I'm going to stop at the end of each page and ask for questions. And obviously the department's here, Rob is here, Anna's here. So hopefully between us, we can, if we can't answer the question right away, we will take the question and answer it on Thursday. So, just to, again, orient you to some of these columns, there's many columns on this page. We're going to be focusing mostly on the initiative text, which describes the initiative. That change package number to its left is the number for the initiative. The initiative justification provides a little more information on why the initiative is being requested. The sort class is just, it's a way of within the program sorting out kind of just topically. So we keep like things together. The fund code is the code that the funding in question comes from. So if you're curious what those mean, I can tell you. So 10 is general fund, 14 is other special revenue accounts, 13 is federal expenditures, 15 is block grants, and 24 is fund for Healthy Maine.
Right at the top.
Yeah, right. It is actually right at the top, isn't it? Yeah. But for those who don't have a sheet, that's what they mean. And then the numbers are at the end. So the total fiscal year 26 and 27, if it's in parentheses, that means it is a savings. If it is not in parentheses, it is more money. All right, so I'm going to hop right into it. So line 1, program Riverview Psychiatric Center. This is change package initiative FA 1407. This reduces funding for the Riverview Psychiatric Center, general fund and disproportionate share due to the facility security being moved to the Department of Public Safety, Bureau of Capitol Police. I know there was some questions asked during the public hearing about that change, which I think probably on Thursday, the department will be prepared to talk more about that. So the shaded line for each of these, I'm not going to read it because it is just the same initiative, just a different fund, fund that is being affected. The next one is line number 3, mental health services, community services, FA 1929. This transfers and reallocates one social services program manager, one position from mental health services community program general fund to the Office of Behavioral Health federal block grant fund and adjust funding for related costs. So you'll see these, the numbers look very similar. Savings on one end, added funds on another end because the funding was shifted to a different funding source. Many of these are very similar. So The Housing First program, this is line number 5, FA 1930, transfers and reallocates one social service program manager position and one public service manager 3 position from general fund to other special revenue funds in the Housing First program, and it adjusts funding for related costs. Line number 7, FA 1932 provides funding to achieve parity with main care cost of living adjustments for certain community behavioral health related services. So those specific programs are main care benefits, manual chapter 3, sections 13, 17, 65, 97, B, 97D, these are appendices, and 97E for uninsured clients. But was not given commensurate funding for the contract, so it's to make up for those programs. And again, that's in the adult behavioral health programming. Yeah.
Something about these today. Can you explain again the shaded area?
Sure.
How
So
that's,
they're different funding sources. So they come from different buckets. Is that, Rob, is that a fair way to describe that?
So it's the same initiative, just across some different programs.
You want to bring him up here
Why
next?
don't you come up here?
Okay, yeah, sure.
You can stay here.
Yeah. All right, so. Yeah, so I'm Rob Stowe. I'm the new analyst over in OFPR. Nice to meet everybody.
Welcome.
So what you're talking about, you see with FA 1932, those are all the same initiative. And then the ones below it in gray, just across the different programs. So like you have this initiative within mental health services community, and then it also goes to Office of Behavioral Health and consent decree. Yep, no problem.
All right.
Yes, Representative.
Thank you. What is, it says it's for uninsured clients. Who are uninsured clients?
So we can either have the department answer that now, or we can take it for Thursday. It's up to you how you want to handle questions.
I'll wait.
There you go. They're jotting down questions. I'm sure you'll get an answer on Thursday.
All right. So, line number 10, residential treatment facilities assessment. This adjusts funding to align allocations with projected expenditures and available resources. Number 11, line number 11, initiative FA 1735 provides funding for the approved reclass of one social services program manager 2 to a social services program manager position, one position to a program manager position in the child care program retroactive to February 27th, 24. This was an employee initiated reclassification. You will see these.
Yep, go ahead.
Sam, I want to, the one right above it where it said to align the allocation with projected expenditures, where we see that throughout the budget. Would you mind just maybe explaining what that means?
I don't want to put words in the department's mouth, so I would defer to them.
Does somebody want to bring a third chair up and?
Because I know we see that often and I can't remember exactly what.
Here. Right in the middle.
Just to clarify more, you're looking at line 10, FA
Correct.
7888.
Correct.
Those are entries related to the revenue forecast changes.
There you
So-
go. That was what I
So
wanted.
there's several changes throughout, and it will pertain to the individual appropriations that they correspond to, but FA 7888, you'll see that several times is revenue forecast.
That's what I couldn't remember. Thank you.
Should we keep Mr. Haber?
If he desires to stay up, otherwise.
I
It's
need
up to you.
more
Okay.
information.
Line 11, childcare services. This initiative provides funding for the, oh wait, I just read that one, sorry. Line 12, I apologize. Office of Child and Family Services Central Office. FA 1737 transfers and reallocates one social services program specialist 2 position from 81% general fund and 19% federal block grant funds to 72% general fund and 28% other special revenue funds. So this is again one of those situations where the funding for a position is being shifted around. Line number 16, FA 1738 provides funding for the approved reorg of one nurse 3 position to a child protective services nurse consultant and transfers and reallocates the position from 100% mental health services children general fund to 72% general fund and 25% other special revenue. So that's the end of this page. Are there any additional questions for any of the initiatives on this page?
Yes, Representative Sager.
Thank you very much, Madam Chair. Thank you for getting us started. I assume that if something is moving from the Department of Health and Human Services responsibility to whoever who has this state, the Capitol Police, that there's an equivalent dollar amount in their budget that their pages that they're looking at, which we're not looking at today, or are there efficiencies recovered by that? And if so, how can we, learn what efficiencies we're achieving by shifting those folks from one department to another?
It's gonna be the musical chair.
I'm Molly Bogart with the department, and this gives me an opportunity to give you all an update too that I wanted to put on mic, which is that we have a memo in development with responses to the questions that you all asked in appropriations, and we've cross-checked that with OPLA's list, so hopefully that has everything that is helpful. We'll get that to you electronically as soon as it's ready and bring copies to the next work session on Thursday. But specific, so this is in that memo, but specifically to that question, yes, there is a companion initiative in the Department of Public Safety's budget. It's a little bit different based on what they need. And we have the full explainer of what is happening here, because I know there were a number of questions about that. So we can talk more about it in detail, but short answer is yes.
So Molly, just before you go, just so I better understand this shift in the security over at Riverview. Currently, we've got some sort of contracted security there.
I'm not sure if it's current or if it has been in the past, but in the past we've had, the hospital has directly paid for a number of officers. That is due to a number of changes in the milieu and how we respond to codes and acute clients and dangerous behaviors has really changed. Our level of need has really changed, where we don't ask Capitol Security to respond to every patient code and things like that. And so what we're doing is moving to a more fee-for-service model with them rather than having standing officers. We have our security needs are met, and then we can call them if we need support for transportation or in the event of some sort of really acute situation. But we are it's no longer appropriate or necessary to have those officers sort of paid for and assigned to the hospital. I'm not sure if we've made that transition yet or not, and I can get that for you. But
thank you.
Yeah.
Yes.
Thank you. I have a question, Molly, if you could get it for me for Thursday. Number 11, where it says social services manager 1 position, that person told the department, hey, I've been doing social services program manager's position. I'd like the pay for it and the title. Could you please bring to me the difference between the two? In other words, what was the person doing that required them to be upgraded? So
not the information about the position, not the different
correct,
financial
the
decision
job
difference.
description of one versus the other that made it the change necessary. Thank you.
Seeing no other questions? Thank you, Molly.
Page 2, Office of Child and Family Services, line number 19, FA 1739 establishes one Child Protection Services case aid position, 79% general fund, 21% other special revenue funds. And this is to support requirements related to the psychotropic medication settlement. I know there was questions asked about that settlement during the work session, and I believe that'll be in the memo as well.
During the public hearing.
Yes, sorry, yes, public hearing. Line 21, FA 1740 establishes one management analyst 2 position, 72% general fund, 28% other special revenue funds in the Office of Child and Family Services to again support the psychotropic medication settlement. Similarly, line 23, FA 1741 establishes 2 Child Protective Services nurse consultant positions, 79% general fund, 21% other special revenue in the Office of Child and Family Services to support the psychotropic medication settlement. Line 25, FA 1742 transfers and reallocates one agency procurement and program administrator position from the Early Childhood Consultation Program general fund to 72% general fund and 28% other special revenue. Line 28, FA 1743 transfers and reallocates one social services program specialist 2 position from 72% general fund and 28% OSR to 50% general fund and 50% federal block grant fund in the early childhood consultation program. And that's page 2.
Questions? No? Let's go on to page 3.
So continuing on that same theme, line 32, FA 1747 provides funding for the approved reorg of 3 social services supervisor positions, funded 79% general fund, 21% OSR in OCFS, and 6 social services supervisor positions funded 70% general fund, 30% other special revenue funds in the state-funded foster care adoption services program, 2 social service program specialist 2 positions retro to February 23rd, 2024, and provides funding for all other related costs. And also provides one-time funding for retroactive payments.
Yes, Representative Graham.
Thank you, Madam Chair. I just, if we could just get a general sense from Bobby, really, there's a lot of shifting around, recognizing. I just want to get a good sense. I think this is in response to many of the concerns people had and about Child Protective Services and so on, and this all kind of reorganization. I just want to have a general sense of how they were looking at that and how they got to those changes for the work session.
Great. Line 36, and we are at Office of Main Care Services now. This is FA 1927, reallocates one social services program manager position from 76% general fund and 24% federal block grant in mental health services children program to 50% general fund and 50% federal expenditures fund. Line 39, FA 1931 transfers and reallocates one social services program specialist 2 position from 72% general fund and 28% other special revenue in Office of Child and Family Services Central to 50% general fund in the mental health services children's program and 50% federal expenditures fund in the Office of Main Care Services program and adjust funding for other related costs. Last one on this page, line 43, FA 1932 provides funding to achieve parity with main care cost of living adjustments for certain community behavioral health related services.
Questions? Yes.
It's kind of an independent question that just dawned on me. Are these going to be posted online? These green?
They have been.
They have been?
Yes.
Have we let Abby know that? Because she's kind of in the dark as to what we're talking about. Representative Griffin.
Oh, I'm so sorry. Yes. So these documents are all posted on the committee website page. They were posted this afternoon.
Thank you.
Maybe.
Yeah, that was. Yeah, we will. And you can tell us that out.
Yeah, and we'll send you a link.
Oh, okay. Yes.
We'll send it to
Representative.
you.
Yeah.
You'll send this?
No, I mean.
The link. Okay.
Thank you.
Okay, we're turning the page. Yep.
All right. Page 4. Line 44, Office of Behavioral Health, FA 1934 provides funding to establish a youth psychiatric residential treatment facility, PRTF, in Maine pursuant to Public Law 23, Chapter 643. And this is a topic that this committee is familiar with. Line 45, FA 7746 provides funding for the approved range change of 9 Child Protective Services Program Administrator positions from a range 28 to a range 30 confidential. That is funded 79% general fund, 21% other special revenue funds in OCFS, and provides funding for related costs. Line 47, FA 7748 establishes 2 management analyst 2 positions funded 72% general fund, 28% other special revenue funds in OCFS Central, and provides funding for related all other costs. It also provides funding to support the requirements related to offsetting the reimbursement of federal income benefits to pay for a child's care. Line 52 provides funding to increase lifespan waiver slots during and beyond the implementation of the new HCBS waiver program. And that is the end of page 4.
Questions, requests for additional info? Yes, Representative Daigle?
Is going to increase how many slots?
For
the lifespan waiver in line 52.
Sorry,
He says it'll increase the
Number of
number of slots, but do we have a number to attach to that?
there is some additional information if you look in the initiative justification. Yes, up to 500 youth, ages 4 to 18, 15 slots for new adult waiver members. We can get that spelled out a little more clearly for you.
Senator.
I guess one of the questions I would have of the department just is, where do we stand on our lifespan waiver? And we've been working on that for a while. It'd be nice to know exactly where we stand on it, especially since we're already putting some monies in the budget for additional slots. That'd be great. Thank you.
Okay. Yes, Representative Shigori.
Also concerning the lifespan waiver, I recall during testimony, there was some concern from some of the people that when we first approved it, that they could stay under the old system if they wanted to. And I just wanted to make sure that was still an available option.
There are heads shaking yes. Yep.
I'll buy that.
Okay.
Great.
Perhaps when we're revisiting this section, we can elaborate on that question on Thursday, unless you want to answer it now.
Yes, that is absolutely still the case. And any transition from a Section 29 or Section 21 service to lifespan, if folks are already enrolled, will be voluntary. So they have the opportunity to move over if they would like to, but there's no obligation. Yeah.
All right, we're on page 5. Medical care payments to providers, line 54, change package number FA 7617, provides funding to replenish 15 reserve slots for individuals determined to be priority 1 waiver program candidates for section 21. Line 56, FA 7888, adjust funding to align allocations with projected expenditures and available resources. So that's that language that Senator Moore had asked about again. This is for developmental services for Maine Care. Line 58, state supplement to federal supplemental security income, notwithstanding any provision of law to the contrary, provides $1 million of the unencumbered balance forward in DHHS state supplement to federal supplemental security income, general fund account, all other line categories lapsing to the unappropriated surplus in the general fund no later than June 30th, 27. Line 59, this is the department-wide, notwithstanding any provision of law to the contrary, 3.6 million of the unencumbered balance in DHHS general fund carrying accounts lapses to unappropriated surplus of the general fund no later than June 30th, 26. Line 60, DHHS FA 1219 reallocates the cost of one social services manager 1 position from 100% general fund to 60% general fund and 40% other special revenue funds. Line 62, this main care FA 2023 reduces funding for the approved reorg of one public service manager 3 to a public service coordinator 1 position and transfers and reallocates the cost of the position from 60% general fund and 40% other special revenue to 50% general fund and 50% federal expenditures fund in the Office of Main Care Services. That's the end of page 5.
Yes, Senator.
I'm just trying to remember the two lines, 58 and 59, where we talk about the transfer or lapsing the unencumbered balance
Balance.
forward. Is that what we do almost every year, or is that normal, or? I don't remember seeing.
Senator Moore, yes, that it does occur quite often. It's done on an ad hoc basis. So we look at the accounts and review what could be potentially returned for general fund savings. These are the accounts identified. The state supplement to federal supplemental security income. That fund has built up over time. The UBF has built up over time. So we are looking to return $1 million of that to the state general fund. The line 59 is department-wide, so we haven't determined what those accounts will be yet, but we will lapse unencumbered balance forward from a set number of accounts by June 30 of
Okay.
the current year.
The current year. The other
Yes,
ones
so
are
we haven't
20
identified those yet, but those will be identified if it stays in the budget.
And the other one was 2027 and 58, June 30th, 2027.
Yes.
Okay. Thank you.
So moving on to page 6, line 66. This is ODES, long-term care, provides funding for a cost of living increase for state-funded home and community-based services related to the department's rule chapter 5, as well as, sections 61, 63, 68, and 69. And that is to maintain parity with how similar main care programs pay for those services. Line 67, Developmental Services Oversight and Advisory Board provides funding for the Maine Developmental Services Oversight and Advisory Board to meet the statutory requirements of Section 34B, Section 1223. Line 68, Disability Rights Maine provides funding for increased costs related to inflation, rental and lease agreements, supplies, sign language interpreters, professional insurance, travel, health insurance, and cost of living wage increases. Line 69, Main Care, FA 1838 provides funding for increased main care disability determination services, 50% general fund, 50% federal expenditures fund within the Office of Main Care Services program, and this is pursuant to HR 1. Line 70, Office of Main Care Services FA 2017 provides funding for the approved reclass of one reimbursement specialist position to a management analyst 1 position that is 50% general fund, 50% federal expenditure fund. Line 73, Office of Main Care Services FA 2020 provides funding for contracted actuarial services, 50% general fund, 50% federal expenditures fund, and that is to assist with forecasting and fiscal management related to HR 1. And that is the end of page 6.
Yes, Representative Shigori.
Yeah, on line 66, it mentions the cost of living increases as of January 1 of 2026, and I'm concerned as to what will happen January 1, 2027, if that just, because that's still part of the same budget cycle. If there's an increase then as well, in order to keep pay adequate.
Somebody want to address that?
So for these particular COLAs, they would continue on throughout the remainder of the biennial. Is that your question?
No, my question is there a further COLA for the start of next year because cost of living is going to increase this year?
There are no other introduced COLAs into this.
Could you possibly price out what it would be to have an adequate COLA for the?
Yes, and that
the
is
last
actually
time?
part of the memo that's being prepared. That was one of the questions that was asked during the presentation of the budget. So that is part of the memo.
Okay,
Yes.
thank you.
Page 7. Line 75, FA 2021, Office of Main Care Services establishes 2 Public Service Coordinator 1 positions and 1 Management Analyst 2 position, 50% general fund, 50% federal expenditures fund. And this is to provide funding related to initiatives required by HR 1. Line 77 establishes 1 limited comprehensive health planner 2 position, funded 50% general fund, 50% federal fund. Again, to assist Office of Main Care Services through June 12th to 27 with the increased eligibility state plan and rulemaking associated with HR 1. Line 79, FA 2027, Main Care establishes 1 provider relation specialist position and 2 eligibility specialist 2 positions. Again, 50% general fund, 50% federal expenditures fund, and again, related to implementation of the requirements of HR 1. Line 81, Main Care, FA 2029, provides funding for staff augmentation, 50% general fund, 50% federal expenditures fund to enable response to forthcoming additional guidance and rules related to HR 1. Line 83, FA 2030 establishes 1 comprehensive health planner 2 position, 50% general fund, 50% federal funds in the Office of Main Care Services to handle representation of program integrity appeals. Line 85, FA 7888, payments to providers, adjust funding to align allocations with projected expenditures and available resources. That is the end of page 7.
Questions on page 7, Senator, and then Representative Graham?
I just want to point out for example, on line 77, where it's providing for 1 or establishes 1 limited period, there is no head count included in the numbers because that is a limited period, correct?
It's a,
Yeah, I don't see a position count.
yeah,
Yeah.
but it says 1 limited in the text.
I'm just asking because it is is that because it's a limited period? Okay. Okay.
We'll double check that.
That they're shaking their heads yes on that one. Because there's no head count. That's why I was just wanting to confirm that that's what I thought. Thank you.
Representative Graham?
Thank you, Madam Chair. Yeah, for Thursday's work session, I'd like to have the total expenditure that we're looking at in order to implement HR 1. My count just quickly here, 8 times that HR 1 is mentioned. I'd just like to know what the total
I
cost
think
is
that's
to
in the memo.
implement HR 1.
That's in the memo.
What we asked for. Sorry.
Page 8, line 86, Main Care, FT 7175. This provides one-time funding for one-time tech adjustments and compliance with new federal legislation. That's HR 1, again, related. And I know there were questions about the technology also that will be addressed in the memo. Line 89, Office for Family Independence, District Office, FA 1837 establishes 35 eligibility specialist 1 positions, 4 Family Independence Unit supervisor positions, 1 Program Administrator Family Independence position within the OFI district program, as well as 1 Management Analyst 2 position, 1 Senior Planner position, 3 Eligibility Specialist 2 positions, and 1 Business Systems Administrator position within the OFI program, 25% general fund, 75% other special revenue. This is related to implementation of the main care work requirements provided or required by HR 1. Line 93, Riverview, FA 1316, adjust funding for positions at Dorothea Dix as a result of the decrease in FMAP for 2027. The new blended FMAP rate for 26-27 is 60.7875%. Lines 97, Riverview, FA 1406, adjusts funding for positions at Riverview as a result of the FMAP percentage change. That's the end of page 8. Page 9. There's a lot of shaded here, so this will go fast. Line 101, FA 2147, provides funding to reduce the FMAP, FMAP for emergency services for non-qualified immigrants who would otherwise qualify for Medicaid expansion from 90% to the base rate pursuant to HR 1. Line 102, FA.
Excuse me for just 1 second. We can hear you, Representative Lemelin. Is there something you'd like to share with the entire class?
Yeah.
Okay. Well, it's disruptive to have you whispering down there.
Line 102, again, medical care payments to providers, adjust funding as a result of the increase in state share of the blended FMAP for fiscal year 27. And then all the way down to line 119, again, payments to providers, adjust funding in the medical care payments to providers program between the general fund and other special revenue funds related to rebasing for hospital tax year from fiscal year 21-22 to fiscal year 23-24. That's the end of page 9.
Yes.
So I see that line 119 is savings. And again, can quickly explain again the rebasing. I know you did talk about it at AFA, but can you help us understand the savings and what rebasing is?
So rebasing quickly is we're changing the year of where the costs are based on for the tax, for the revenue. What is happening with rebasing, what you see here on lines 119 and 120, is you see a reduction in the general fund and an increase in the special revenue. So the revenue represents the increased amount that is received from hospitals, increased revenue is received from hospitals, and there's a corresponding reduction to the general fund.
Page 10. Line 121, payments to providers, FA 7172, provides additional funding to cover increased hospital costs. And this is a companion initiative to hospital tax rebasing and reinvest the additional general fund revenue to cover increased hospital costs. Line 123, FA 1613, main care, adjust funding in the Office of Main Care Services Federal Expenditures Fund between all other and personal services to correct the allocation of the funding approved in Public Law 25, Chapter 388, which established positions for the HCBS lifespan waiver. Line 124, medical care payments to providers, FA 2143, provides funding to increase main care appropriations and allocations to reflect trends in healthcare costs and enrollment. Line 139, payments to providers, FA 2150, provides funding for the annual Medicare Part D rate increase. Line 141, payments to providers, FA 2151, provides one-time funding for a 2.5% temporary rate increase to the Medicare physician fee schedule pursuant to HR 1. That's the end of page 10.
Yeah.
Yes, go ahead.
When we're looking at 124, and then you've got all the grade area, 125 through 138. So they're all corresponding then to funding to reflect the trends in the healthcare costs and enrollment? Is that what we're looking at?
Yes, that's correct.
Okay, across all of the different codes
Yes.
or programs, I should say.
Yes.
Wow. That's a lot. Okay, thank you.
Right. Page 11, line 144, payments to providers, FA 7173, provides one-time funding to offset the provider impact to the federal budget reconciliation law, Public Law 11921, Section 7113, which prohibits federal match for payments to prohibited entities as defined in Section 7111 for items and services for a one-year period beginning July 4th, 2025. Line 145, payments to providers, FA 7171, provides additional funding to increase supplemental payments to private psychiatric hospitals. Line 147, nursing facilities, FA 7155, provides funding to reflect meaningful cost differences faced by the Maine Veterans Homes nursing facilities and per diem rates for services provided Maine Care members. Line 150, payments to providers, FA 7174, again, one-time funding for supplemental payment to the Maine Veterans Home for Maine Care members. Line 153, nursing facilities, FA 7888, adjust funding to align allocations with projected expenditures and available resources. Line 154, OFI, District Office, FA 1834, reallocates positions within OFI as a result of the decrease in SNAP federal financial participation rates from 50 to 25% as of October 1, 26, pursuant to HR 1. Line 158 OFI FA 1835 adjusts funding between general fund and other special revenue funds in both OFI district program and the office and OFI program, between general funds and general expenditures fund in the food supplement administration program as a result of the decrease in SNAP funding participation rates from 50 to 25% as of October 1, 26 pursuant to HR 1. That's the end of page 11. Page 12, line 164. OFI District Office FA 1836 establishes 40 eligibility specialist 2 positions and 4 family independence unit supervisor positions in OFI. District program funded 44.8% general fund and 55.2% other special revenue funds to improve the SNAP payment error rate pursuant to HR 1. Line 166, OFI FA 1839 provides funding for OFI for the projected increase in postage pursuant to HR 1. Line 168, OFI FA 1840 provides funding for OFI for the projected increase in income verification services pursuant to HR 1. Line 170, Food Supplement Administration FA 1837 provides funding for heating assistance benefits for SNAP participants to improve the payment error rate. Line 171, OFI provides one-time funding for technology adjustments in compliance with HR 1. That's the end of page 12.
Just a heads up, I kind of have
And then some continuation of that last initiative on the top. We've got okay. Line 174, Maine CDC FA 1127 provides funding for the approved reclass of 1 public health educator 3 to a comprehensive health planner 2 position retroactive to February 11th, 25, and funding for related all other costs. Also, Maine CDC FA 1128 establishes 1 health program manager position funded 50% general fund, 50% federal funds in Maine CDC to oversee investigations, outbreaks, surveillance, and disease prevention for sexually transmitted infections and HIV, and provides funding for related all other costs. Line 177 CDC FA 1129 establishes 1 health educator 3 position, 100% funded Maine CDC general fund to support disease prevention and surveillance for sexually transmitted infections, including congenital syphilis and HIV. Line 178, FA 1130, CDC provides funding to increase the hours of one part-time chemist 2 position in the environmental testing lab for seized drugs from 32 to 80 hours biweekly, 62% general fund, 38% other special revenue funds. That's the end of page 13. Last page of the green sheet. Line 180, Universal Childhood Immunization Program. That does have a new name now. It's the Universal Immunization Program, and it provides funding to align with available resources. Line 181, Office of Behavioral Health provides FA 1933 provides funding for ongoing support for adult treatment recovery courts in Oxford County and Region 6. That is the end of the green sheet.
Questions from anyone on the committee on the green sheet in anticipation of actually taking votes on Thursday? Seeing none.
We've got the purple sheet. This is the language. As you recall, for each of the language parts, there's an associated part on the green sheet. And that is noted under part notes.
I do.
In the columns here. Well, yes, 3 don't have it.
Yeah.
All right, so I'll start at the top here. Line 182, part L. This part changes the base year for the hospital tax from hospital fiscal year 22 to hospital fiscal year 24. This is effective with the May 15th to 2026 payment. And that's related to lines 119 and 120. Line 183, DHHS management, this is part T. So sections T12, T13, and T14 provide for transfers from the Budget Stabilization Fund to DHHS OFI and Office of Main Care Services to provide one-time funding for technology adjustments and compliance with HR 1. And that's associated with lines 86 to 88 and 171 to 173 on your green sheet. Next, nursing facilities, part WW. This part requires DHHS to establish reimbursement rates for the main veterans' homes, nursing facilities covered by the Main Care program. It requires Main Care to reimburse the veterans' facilities for covered nursing home services on a per resident daily rate basis that is reasonable and adequate to cover the total Main Care allowable costs of operating those facilities. The per diem calculated pursuant to this section for veterans nursing homes comprises total nursing facility reimbursement for veterans facilities. The per diems developed under this section must be adjusted for inflation to the same extent that reimbursement rates for non-veterans nursing facilities are adjusted. This part also requires DHHS to make a one-time supplemental payment to the veterans homes residential care facilities in fiscal year 26-27 to cover the difference between Main Care payments and actual allowed costs. Lastly, this part directs the department to use funds previously appropriated for supplemental payments.
I have a quick question for that. Thank you. Do we do we get federal dollars around the veterans homes, or is it this all on the state budget?
So there's the regular Main Care match.
Just the Main Care, but nothing above what Main Care does? No veterans dollars or any of that VA type dollars?
We might have to get back.
Thursday's fine.
I think MDH is to answer that. We've only talked about the Main Care and funding.
Okay.
But thanks.
XX, part XX. This part permits the department to directly issue an annual heating assistance payment to SNAP households. And that's related to line 170. Part YY, this part removes the legislative requirement that DHHS provide $3 million to the Maine State Housing Authority for use in programs under their jurisdiction. Part AAA, Public Law 25, Chapter 388, appropriated funding for supplemental payments to private psychiatric hospitals. This act provides additional funding for those supplemental payments and clarifies that the total supplemental payment amount includes appropriations from multiple acts. DHHS management. This is part BBB. This part authorizes DHHS to adopt emergency rules to implement any provisions of this act over which it has specific authority that has not been addressed by some other part of the act without the necessity of demonstrating that immediate adoption is necessary to avoid a threat to public health, safety, or welfare. Part CCC, this part lapses $1 million of unencumbered balance within the state supplement to federal supplemental security income program, general fund account to the unappropriated surplus of the general fund no later than June 30th, 27. And DDD lapses 3.6 million of unencumbered balance within the DHHS general fund carrying accounts to the unappropriated surplus of the general fund no later than June 30th, 26. And finally, triple E, this part authorizes DHHS to transfer personal services to the all other and capital expenditures line categories in order to fund the replacement of the camera and access control system at Dorothea Dix, rate determinations for main care services, and a comprehensive benchmark analysis for Medicaid rates. And that is it.
Questions? Seeing none. Oh, Representative Zig. Yep.
Thank you, Madam Chair, and everyone. I know it's late. Line 180. I think it's one. Yes, I know it's not a language item, but that $10 million, that's going to be backfilled after FY27 with the assessment. Is that correct? This is the universal immunization program.
That is actually just, let me make sure I'm using the right term. That is just an allocation. So it's not actually 10 million in general fund, it's 10 million. That 10 million is the assessment. This is the authority for us to spend the increased assessment related to the expansion to adult coverage of adults. And
the
so,
federal expenditures fund. Okay.
Yeah.
Thank you. Appreciate it.
yeah.
Thanks for the clarification. Thank you.
Yeah, it's other special revenue. So that is, it's 14. I think there's a missing comma between federal expenditures and 014. But it's all the fee and then the authority to spend the income from the fee.
Representative Shigori.
Yep, Molly, don't go away. The $190 million that's in the HR1. Is that, I know that's something that's being negotiated between the department and the feds, but is that going to come before us in any sort of a supplemental budget or anything, just to see how it's finally going to be spent? And does the Appropriations Committee have to appropriate that in some way?
The Rural Health Transformation Fund, I think is what you're talking about. And that does not go through a normal appropriations process. It's like other grants to the to states and other for other programs. So we are negotiating the budget with CMS as they had feedback on the original budget. The full proposal, including the budget and the narrative, are posted online for folks, but due to just the nature of it, it's not something that would go through the normal appropriations process, but also the timeline. It's gone through stakeholder engagement and work like that. But I know that, we're happy, especially once we get sign off from CMS on the initiatives, to come before the committee and talk to you all and provide more information if helpful.
Thank you.
Yeah.
Seeing no other questions at all. Thank you all for being here today. Anything else for us?
Not today.
Okay,
So we'll
so
see you
I would
tomorrow.
entertain a motion to adjourn.
Cut off on
Okay.
WW. Should I reprint those?